Good afternoon to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Padma Shri Dr. Kamini A. Rao. Ma'am is MBBS, DGO, DORP, DCH, FRCOG UK, FICOG, PG, MLE, Law, FNAMS, Chairperson of the International Institute for Training and Research in Reproductive Health, and also founder and medical director of Milan Fertility and Birthing Hospital, Bangalore. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is recent advances and role of artificial intelligence in art. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you very much. And I am sorry that I have been late for personal emergencies. As a doctor, I'm sure all of you will understand. There will always be emergencies because of professional hazards that we all go through. But without any delay, let us now go into the subject given to me today. And we'll start with recent advances and the role of AI in art. I'm sure all of you understand that there has been a lot of advances and they continue to be a lot of advances in ART, and not a day goes by without a newspaper insert about what happens, good or bad, in assisted reproduction. And now, with the law coming in, we have even more publicity coming in with the ART. So we must look at it. So if we were to go through the timelines of a key event in the ART, we'll start from the 1970s, where Louise Brown was born in 1978, and then the 80s, we go to 1990s. In 1992, we had the development of ICSI, and then we went to 1999 when we had Gardner and Schoolcraft, where the classification took place in a lot of the IVF, and 2001 birth of the first cryopreserved embryo took place. 2000s, the first single embryo transfer took place of the frozen embryos, and the development of 2013 of the time-lapse imaging, which allowed us to see the development of the embryo from just an oocyte and a sperm as gametes to the entire 5 days into a blastocyst. So, what other modalities are we looking at? Now we know that as far as the advances are concerned, it will be looking at the endometrium, that is the blood flow, the PI and the RI. The Sonovac will tell you the sonography-based automated volume count for stromal ovarian blood flow estimation and a 3D evaluation of cysts, etc. That's called the Sonura system. And then we have the endometrial receptivity array, which will tell you the exact window of implantation to determine and facilitate a single embryo transfer, and a fertiloscope which can go through the laparoscope, the vagina, using saline solution instead of carbon dioxide. And then we are also looking at the sperm DNA assessment in looking at the DNA fragmentation called the DFI. Now, 30 to 50% of fragmentation in the sperm head can spell disaster. Even if the count can be 100 million, you can still have a problem. Now, how do you assess the fragmentation index. It could be through sperm chromatin structure assay, a comet assay, tunnel assay, sperm chromatin dispersion, and of course, we can also look at the acridine orange test. Looking at now the advances in the diagnostic modalities, look at the omics and non-invasive markers for endometrial receptivity. We have the microRNA, we have the proteins, and we have the cell-free DNA. Yeah, circulating endometrial cells. In the blood, look for single cell and cell-free content in terms of transcriptomics, proteomic analysis, and metabolomics. Because we're looking at functionality and we're not just looking for markers which are just plus and minus, no qualitative, we're looking at quantitative. What about the cervical swab? Single cell and cell-free content, transcriptomics, microbiome analysis, that is bacterial, 116S PCR, and analysis. Look at the urine, single cell transcriptomics, which are all the excreta from the body, where you can also see the metabolomic analysis, the GCMS, proteomic analysis, where you have all these proteins, and a microarray, which will top it up. Then whole mouth saliva. Again, you can do a metabolomic analysis. So, why are we worried about any invasive procedure? So you have saliva, you have blood, you have cervical swab, and you have urine. So now the new tests, again, the current tests will look at a comprehensive analysis. Now, we are now wanting an optimal window of implantation. Then you're looking at a suboptimal window of implantation and a non-optimal window of implantation. So the more the samples from the body, the better is going to be the chances of us hitting the bullseye. So, advances in newer therapeutics. What are the advances in terms of the drugs? We know that corifolitropen alpha is a hybrid FSH molecule. Then a corifolitropen delta, a Pergoveris, elagolix, oral GnRH antagonist, which is a second generation antagonist. And now for even triggers, we have the synthetic kisspeptins. Now, advances in the laboratory techniques. Gone are the days when I started my embryology way back in 1989. I never thought that I would get into an embryology where I had so many incubators. Okay? I never thought I'll have so many incubators. But lo and behold, the so many incubators does not mean that you're in a high-tech institution, but quality demands that you keep these incubators to prevent cross-infection, and also the fact that you don't open these incubators time and again to reinsert embryos after checking them. And secondly, you also make sure that these embryos are kept very similar to what would happen in vivo inside the body. Now look at the sperm selection techniques. You have an electrophoretic sperm separation technique here. Look at the precursor germ cells and white cells here. Look at the MAX, what we call as magnetic activated cell sorting system. What happens is the sperms are now fed through this cylindrical system, and you will find that the magnets are put here on either side. What does the magnets actually do? Now you have the annexin V Then you have the phosphatidyl serine and the apoptotic sperms and the non-apoptotic sperms. So the blue ones are the non-apoptotic sperms and the red ones are the apoptotic sperms. Now, what is the apoptotic sperms? Because the apoptotic sperms are not good enough for fertilization, gets attached to the annexin dye. And what flows through as a clean specimen will be the non-apoptotic sperm fraction. The advantage of this max is that what preparation that you would take for half an hour to 45 minutes is done within a matter of 2 to 3 minutes. Especially in an IVF, time is an essence. So, max becomes a very important step in advances in terms of getting the best sperms sorted at a very short time. Now, you must have heard about IMSI M zone. So, what is this M zone? Motile sperm organelle morphology examination. Now, you're taking this microscope and magnifying it to almost 6,000x. And in that, you'll be able to see the abnormal sperm in the head. So trying and picking up how normal is normal at naked eye level at 200x may not be as normal at 6,000x. So look at this now. What was appearing normal, now this has got vacuoles in the head. So this will be discarded. Now, if you look at this will also be discarded because it's got vacuoles. Look at this now. Okay, so out of the 4 sperms that I have, I can only pick up 1 sperm, which would have been almost considered as 4 sperms being normal. I'm now able to take up in this particular marathon, I'm able to pick up only 1 sperm, which is almost 25% only. So this IMSI M zone, which will be able to now pick up when I do ICSI, and M zone IMSI will further let me know that how can I get the best sperm to fertilize the oocyte. Now look at the embryology advancements. Now this is a poloscope. What does the poloscope and rescue say? The poloscope actually gets you to independently orient yourself in looking at the muscles mitotic spindle. Okay, in an M2 oocyte. Now, once you know the spindle, it's beautiful spindle, it's extremely important not to puncture it. This is not seen through the microscope, regular microscope. You need a birefringence microscope, and that poloscope that is attached to it is going to tell you where it is. So, if you keep your gamete aligned at 90 degrees to it, there is no way you are going to harm that. So the chances that you are going to get gametes after ICSI turning into embryos is much higher. So ICSI performed on the day 1 after visualization of the muscle spindle of an M2 is rescue ICSI, and it avoids a damage to the mitotic spindle. The other thing you must have heard is that especially when there is a failure of fertilization, we call an assisted oocyte activation. Now, what is that activation? Here, there's a mechanical activation here. Now, the assisted oocyte activation is performed using the calcium chloride, electrical pulses, mechanical methods, and vigorous cytoplasmic aspiration. And the aim is to reduce fertilization failures in ICSI cases. So this is assisted fertilization, and this is through mechanical growth. So therefore, the chemical activation is also there, and electrical activation is there. So there are three ways of doing assisted oocyte activation. The third one that you're seeing here in advances is the embryoscope. So it's a time lapse imaging. So TLI. So see how you look at the development from a 2-cell to a 4-cell, and then you see how it goes, because there is pictures taken of it throughout at regular intervals, and you will see at what stage there has been a delay, and then you'll see the time taken to blastocyst. So this marathon race can be timed. So in that way, you can also select the best quality embryos. So each embryo is tracked in its own container, and therefore you can pick up and select the best embryo that has reached based on the growth rate of that embryo. Okay. Now, when you look at the genetic testing, that is a PGTA for aneuploidy, PGTM testing for single gene disorders, and PGTSR testing for structural rearrangements. So what happens here is it's a PGT, which is, of course, it's an invasive procedure. You go through the zona and you go and get one blastomere out and you test. The non-invasive PGT will be to take the fluid around the gamete or the embryo and then test the cell-free DNA that is left, which is the indirect evidence to say if there is a problem or not. Next, laser-assisted hatching, which is a highly focused infrared laser beam to remove, okay, the precise increments and shown to increase the clinical pregnancy
This
rate.
video shows laser-assisted hatching being done on a day 3 8-cell embryo. The laser fires in the area of the red circle. We pulse the laser once, twice, and a third time. Now the hatching is completed, and there is a gap in the shell at the red arrow. Assisted hatching is believed to make it easier for the embryo to hatch out of its shell, thereby increasing the probability of implantation and pregnancy.
So, the next stage would be, how do you freeze them? You either go through a very fast freezing technique, like you see how those penguins are going, irrespective of where they are standing, they will just jump into the water. And this is vitrification. Very fast cooling, more cryoprotectants used, less damage due to ice crystal formation, and cell survival is high. So in this red arrow, you will see from this 20 or 30 degrees, it just gets plunged into minus 40 degrees. That is vitrification. But look at the other people, like in Britain, for everything they form a line. Okay? But what they do is that they say take a line, however urgent it may be. But nevertheless, they always feel that the line is the best, slow freezing. So one after the other, they jump into the water. So slow cooling, less cryoprotectants use, and damage to the cells due to vitrification, that is crystallization and ice formation in the cells, and the cell survival is poor. What happens is it takes a long time. This is the blue, right? It goes down and down slowly, and then it goes to minus 186 here. So there are two things. One is slow and one is now. most of the people now believe that the fast freezing is better. Okay, so if you look at a vitrified glass drop, which is here, and you see the frozen drop, which is crystallized into ice over here. So it can even break the cell membrane, and sometimes doesn't give you a response when you thaw it later. Now look at the advanced therapies that we have. Now PRP for ovarian and endometrial rejuvenation. So platelet-rich plasma separation and platelet activation. We have with platelet-rich plasma, they prepare platelet poor plasma first on the top and platelet-rich plasma at the bottom, in the middle layer, and then there are only red blood cells at the bottom. So how do they do that? They get the whole blood, they stand it for some time, and then they centrifuge it. So what does this ovarian PRP do? It's giving you increased pregnancy rates, and positive results appear to be short term for 2 to 6 months and after the procedure. Now endometrial PRP in infertile women with thin endometrium of less than 6 mm with significant increase in pregnancy rates. Now here, PRP intraovarian via the transvaginal or laparoscopic route, it goes into the cortex. Okay, and here what they do is intraovarian via transvaginal route or translaparoscopic. They usually prefer a translaparoscopic route because they can actually stabilize the ovary. It's important not to get into the medulla of the ovary, but into the cortex itself so as to rejuvenate the ovaries which are concentrated in the cortex. The other thing is, of course, follicular growth is enhanced with the this PRP. So that is the principle that is used in this case. The second, also, the other things are that while you are putting all these things in, the follicular growth is enhanced after the PRP injection. You also have the vascular endothelial growth factors and the follicular growth factors and the insulin-like growth factors all working, which increases the angiogenesis in the ovary and also allows the reactivation of the follicles. Then you have all these TGF alpha and the HCGF and all these other things which are neurotrophins which increase the follicular genesis. So what we are expecting is at best now is a prediction that some of the people will definitely improve. And if you look at it, that most of these people are people who are younger than the elderly people. So those who have reached premature menopause, but who will still have a rough count of about 1,000 primordial follicles in the ovary. Now look at the mitochondrial replacement therapy for 3-parent children. So there is a pro-nuclear transfer here. This is the patient here, and this is the abnormal mitochondria here. What they do is they go on this basis that they pull out the nucleus of the patient who has the mitochondrial disease, and they take out the mitochondrial of the donor nucleus and keep it aside. So they take the nucleus of the indenting couple of the woman and put it into the donor cytoplasm whose nucleus has been enucleated. Okay? So, since it's been enucleated, you will have a donor cytoplasm with the donor mitochondria, but the nucleus and the DNA of the nucleus is going to be of the intended couple. So why do they say 3-parent baby? Because the mitochondrial DNA is going to be of the donor. The regular DNA is going to be of the intending woman. And then, of course, the husband's DNA is also going to be included, which makes it 3-parent babies. So, if you look at that, that is what is being explained here. All right. So, cryopreservation of the ovaries, retrieval of one ovary, okay. And then you see that the preparation of the cortical tissue is made into small bits here so that the entire cortical tissue need not be, sort of frozen as a whole, because the cryoprotectant may not actually go through the entire piece of the ovary. And then what happens is, it is then put into a cryotube, frozen, and where it is required, and after the woman has gone through all the treatment, it is then that she is prepared well before we try to put the cryopreserved tissue back inside. So it is thawed, it's put into a petri dish and into the culture fluid, into this flat bottomed beakers. And then what happens is it's brought to the room temperature. And once it comes to the room temperature, it's either done by the laparoscopic route, because they would have kept the ovarian fossa still vacant. And they will use this to cover the deficiency in the ovaries first. And sometimes the ovarian fossa may be blocked due to adhesions. I've seen this ovary also being transplanted into the forearm of the individual, provided they get a good blood supply. So once after that is sorted out, we find that she will start feeling better. And once after 2 or 3 months and she has started regular periods, then you can go and stimulate and get her to get a pregnancy done. Now let us look at the artificial intelligence. We've seen the advances in ART, the artificial. How does artificial intelligence come into ART? I thought ART itself requires a lot of intelligence, but my dear friends, you have to learn much more. It's the use of the computer which can perform human functions such as learning from experience, adjusting to new inputs, and stimulating human brain intelligence and performing human tasks, which in short means that you can't replace the human, but certainly you can take out the monotonous tasks that the human does, which it can lead to mistakes and allow just 5% of his brain to be used to get the best efficiency and effectiveness of the human. And advantages have shown that AI enhances pregnancy success, reduces the number of IVF cycles, minimizes failures and invasive tests, and avoids multiple pregnancies. So where can it be used? It can be used in gamete selection, embryo selection, and of course in the treatment regimen. So if you look at the gamete selection, oocytes occur at different stages of their maturation process, as in the mature M2 oocyte, mature M1, and of course the DEG, and etc. So if you look at the oocyte imaging before and during HC, select oocytes with the highest developmental potential and quality based on their morphology and maturation, and image-based oocyte scoring. What about the gamete selection for the sperm? We have CASA, which is again computer-aided semen analysis, and the selection of the most potent sperm based on morphology, concentration, and motility. The recent advances that we have seen in CASA to evaluate sperm hyperactivation, advanced algorithms, and can analyze vitality, acrosome reaction, DNA fragmentation, and the presence of leukocytes in a sample. So let's look at this picture. The gamete selection in the embryo. The high quality embryo selection by using CNN, that is convolutional neural network, and the RNA, that is recurrent neural network. So we have two things, convolutional neural network and recurrent neural network. To successfully predicting euploidy of embryos in a non-invasive manner, which is what we really want. The third one is morphokinetic analysis or time-lapse imaging provides continuous data regarding embryo development. So there comes our personalized medicine. Just a minute. Well, 3 o'clock, they've told them. Understand? Yeah. So this gets us to the next stage of personalized medicine. What do we mean by personalized medicine? That means we look at each person and actually design the medicine to suit that person rather than take this medicine for this person, etc., depending on what we did on, say, 30 people on some other kind of medicine. So the big data is looking at all the medical records, electronic medical records, looking at a lot of cloud data, image databases, hospital data, etc. And then looking at the natural language processing and machine learning algorithms. So one is supervised machine learning, unsupervised machine learning, and reinforced machine learning, and put them all together and training and testing on the model. So what happens is we are using large data sets, predicts patient-specific regime, personalized medicine, and discovers in the process novel markers that will predict fertility. So, if you're looking at prediction, prevention, and personalization of treatment, we will look at one is the diagnosis. So if you look at, just give me 1 minute. If you look at the predictive one, it is in diagnosis, that is imaging and screening, genomics and other omics. Then this is electronic records, medical history, plasma samples, and semen analysis. But If you're looking at prevention, we're looking at the longitudinal AMH testing, fertility checkups, discovery of risk factors and their interactions like lifestyle and environmental genetics. Then personalized would be treatments like oocyte images, genomics, and other omics, and metabolomics and embryo cultures and embryo images. But if you're looking at the big data in terms of the M health and devices and apps, remote patient tracking and digital health, where there is a participation of the community. So if you take AI in prediction, prevention, and personalization of treatment, then you have all of them included. So if you take this, you will be able to chart this out on a long-term basis with the community, thereby reducing the amount of reinventing the wheel. So what does the future hold for ART? IVF on a chip, microfluidics. We are decentralizing the whole thing rather than having it more to a metro and to see that it is all hi-fi. We are taking into the community and making infertility more by choice than chance. Stem cell therapy and in vitro gametogenesis, bioengineered endometrium, bioengineered uterus, gene editing, ovarian tissue transplant, and an artificial womb. What about microfluidics in ART IVF on a chip? Yes, that is possible. You can have, starting from infertility diagnosis, a sperm selection, sperm guidance, oocyte analysis, insemination, embryo culture, embryo selection, vitrification, and that is based on droplet-based microfluidics. And then, of course, with continuous flow of microfluidics, it can then be able to provide infertility even in the peripheral areas. Now, this is an interesting concept, which will almost mean like Star Wars, in vitro gametogenesis with stem cells. You have an infertile couple here. So you start saying, let's connect the somatic cells. Now, somatic cells are all diploid. So you take the somatic cells here, and if you've got the somatic cells, then what do? The somatic cells are all mature, isn't it? So mature somatic cells will all be diploid. Yeah? Yeah. So what are the cells you can take? You can take the fibroblasts, you can take the blood cells, you can take the muscle, you can take the adipocytes and the epithelial cells. But since they are already mature cells, you'll have to reprogram them. That means you'll have to use the proteins, the mRNA, to regulate them. And these are the genes that will help you to re-regulate them. What happens then? Then these are person-specific, okay, interstitial, pluripotent stem cells. And then a germ line is created. Once this germ line is created, human primordial germ cell-like cells, they get inducted with specific cytokine and growth factors. Here, it's important for us to note that they can become oocyte-like cells or spermatid-like cells. So, voila, this woman didn't have eggs. Now you've created eggs for her. Likewise, this woman has a husband who doesn't have sperms. So in her body, you also created sperms. My God, can this happen? Yes, maybe by 2030, there can be no requirement for donor egg or donor sperms. Now you can take these two and they can come through the fibroblasts, and then fertilization can occur and a genetically related offspring comes out of that. So, what about the bioengineered endometrium? Now, bioengineered endometrium applications are also possible. It helps for implantation research, morphology, and receptivity. It avoids animal models and studies and is useful to study the effect of drugs and hormones at human cellular level. What is this bioengineered uterus? It's the generation of the uterus by tissue engineered techniques to treat patients without a functional or a well-structured uterus, and templates and scaffolds made from synthetic biomaterials and materials decellularized matrices used to generate the uterus. Then, gene editing. DNA is inserted, deleted, modified, or replaced in the genome of the living cell. So what happens? These technologies are very, very current, relevant, and it is utilized. So clustered, regularly interspaced, short palindromic repeats. So this is called a CRISPR technology. So transcription activator like effector nucleases are called TALENs. And the ZFNs are called zinc finger nucleases. What about uterine ovarian transplants? It involves transplanting ovarian tissue from a donor or the patient's own body to restore fertility. Now, this is the beauty. At the end of my talk, I'd love you to listen to this. And with this, I will close my talk.
Introducing Ectolife, the world's first artificial womb facility, powered entirely by renewable energy. Ectolife allows infertile couple to conceive a baby and become the true biological parents of their own offspring. The facility features 75 highly equipped labs. Each state-of-the-art lab can accommodate up to 400 growth pods or artificial wombs. A single building can incubate up to 30,000 lab-grown babies per year. Ectolife allows your baby to develop in an infection-free environment. The pods are made of materials that prevent germs from sticking to their surfaces. Every growth pod features sensors that can monitor your baby's vital signs, including heartbeat, temperature, blood pressure, breathing rate, and oxygen saturation. The artificial intelligence-based system also monitors the physical features of your baby and reports any potential genetic abnormalities. The pods are equipped with a screen that displays real-time data on the developmental progress of your baby. A special section in the app allows you to watch a time lapse of your baby's growth and share it directly with your loved ones. Ectolife growth pods feature internal speakers that play a wide range of words and music to your baby. Through the app, you can choose the playlist that your baby listens to. Thanks to a 360 degrees camera that's fitted inside your baby's growth pod, you can use your virtual reality headset to explore what it's like to be in your baby's place. With Ectolife, your baby will receive the best nutrients that can support their growth. Each group of pods is connected to 2 central bioreactors. The first bioreactor contains nutrients and oxygen, which are supplied to your baby through an artificial umbilical cord. This bioreactor also contains a liquid solution that serves as the amniotic fluid that surrounds babies in the mother's uterus. It's rich of vital hormones, growth factors, and antibodies that sustain your baby's growth and development. Thanks to a system controlled by artificial intelligence, each baby receives custom nutrients tailored to their needs. The second bioreactor is designed to eliminate any waste products produced by the babies. The artificial umbilical cord helps the babies to release their waste products into the second bioreactor. With the help of a delicate layer of engineered enzymes, the second bioreactor can then recycle waste products and turn them back into useful nutrients. Prior to placing the fertilized embryo of your baby inside the growth pod, in vitro fertilization is used to create and select the most viable and genetically superior embryo. Say goodbye to the pain of childbirth and birth-related muscle contractions. Actolife provides you a safe, pain-free alternative that helps you deliver your baby without stress. You can use Actolife growth pods at the comfort of your home, allowing you to incubate your baby in your building without the need to visit our factory.
So, to conclude, infertility, with its varied causes, has a potential need for advances technologies for treatment to improve success rates. Advances in technologies like AI, better instrumentation, and diagnostic aids have made it possible to explore new avenues in investigations and treatment. Appropriate use of technology is sure to improve the live birth rates and is the main aim of any infertility treatment, so that infertility need not be a pain but can be a boon, so that infertility is by choice and not by chance. Thank you very much.
Thank you so much, ma'am, for your wonderful presentation. Ma'am, we do have some question if you like to take that up.
Yeah, please go ahead.
So, ma'am, the first question is, what ethical consideration should art practitioners take into account when integrating AI into their practice?
I think we have the ART law with us, and within the ambit of the ART law, I think we can go ahead and we can practice. I don't think anything else will come in the way. Unless they have anything specific in the AI that they want to ask me.
Ma'am, the next question is, what steps should be taken to ensure responsible and transparent integration of AI technology into the art workflow?
In fact, AI technology itself is very transparent. If you use AI technology, it's basically to make it more efficient and more transparent, and besides to avoid mix-up. And if you're using it correctly, it is going to help you to become more transparent, ethical, and it's going to make it efficient. And the fact is that wherever there are human errors, this is going to ease it out. So technology, in fact, when we introduced the computer made a lot of the human errors, eliminate the human errors. Same way where I showed you all this technology, it is actually going to take away the kind of errors that can come due to exhaustion and monotony in typing for the person. And in all the peripheral areas, and in say level 2 centers in the periphery, you may not have that many qualified people to help them out. So in such a situation, machine learning becomes a boon for these doctors in terms of documentation. So I think that documentation using AI will be a boon for them.
Ma'am, there's one last question. What are the primary challenges faced by art specialists in the achieving successful outcomes, and how can AI help address these challenges?
I think the primary challenges here are exactly to follow the rules, in terms of qualifications of the doctor, in terms of specifications of the site, in terms of the quality of the equipments, as well as the disposables. And these are the things that have to be followed. And that itself takes some time. We don't have that many qualified embryologists, for example. We don't have that many qualified andrologists in the center. And most of these people will have, people on the name over there on the board, but they're actually not present on their letterheads. So what is happening is the government is going to clamp down on all these centers. Because today, what I hear from the government, that they're not going to take it lightly. So they are very, very clear that if anything like this happens, they are definitely going to make an example of it. Because they feel right now that you don't need so many IVF centers, which I tend to agree. Secondly, the kind of activities that are going right now is only because of the documentation process. People are actually getting caught. And I think, we have come to a stage where documentation becomes increasingly important, particularly when you're dealing with gametes and you're actually going to have the trust of the public on us. We can't afford to, tell them that, yes, yes, it's your gamete. What happens if they go and get a DNA test on the baby and they find that the DNA does not match? You see, what happens is it's a kind of mistrust that is going to go across the entire fraternity. So we don't really need to have that kind of knee-jerk reaction. So I feel today that we are waiting for a nuclear bomb to erupt, because too much of hype and too much of IVF, I think because there is a technology, people should not misuse the technology, and it should be used judiciously, because if you overuse a technology when it's not required, you are bound to raise the eyeballs of people, and there are chances, if not used properly, there's a chance that you may get caught on this.
Thank you so much, ma'am, for answering all our questions. That's all from our audience, ma'am. And before concluding, ma'am, any last remark from you?
Well, I think, infertility as a condition now has been diagnosed by WHO as a. It has also now come into the insurance. Also, it is a condition which has a medico-social issue. So I think we need to be very careful. We need to be sensitive. And at the same time, we need to be focused. We need to give them just what they need. We don't need to go overboard. Out of every 10 infertile couples, I think only two need IVF. So don't treat everyone with IVF, and that is what is getting a bad name. Many times, stress plays a very important role in infertility. So if we can go ahead and try and counsel people like the good old days, people have forgotten that people can get pregnant naturally. So please spend some time, talk to them, and then go ahead. Because I think people still can get pregnant. Out of every 10 people, at least 2 or 3, after coming and visiting you and talking to you and just certifying them that they're okay, they go out, and then in the next 3 to 4 months, they come back pregnant. So it's all depending on the doctor-patient relationship. And that's what I would like to say. Re-establish the doctor-patient relationship so that the patient feels more at home. That's what I want to say.
Thank you so much, ma'am, for joining us today. And it was an excellent session with you, ma'am.